as we are waiting for the session actual time to start, 12 o'clock, just because we are all sitting here, we'll just start talking. Multifocal IOLs. See, I'll first go into surgical techniques, but then we should know that we have to select a patient. The patient has to have a drive. He or she should want to have a multifocal. And then we should evaluate properly, exclude people who are not fit to be taken. That will all be covered. And then start off with the surgical technique. Surgical technique is no different. It's just like a cataract surgery. So any cataract surgery. But the pressure is on because most of these multifocal IOLs come as single piece IOLs. So it's very, very difficult to implant it if you have a PC rent or even if you have a Rexis. So there are multi-piece IOLs which AMO makes, but then no financial interest in this. But most probably you will be having only one lens, and then you will be under little pressure to have that implanted into the capsular bag. So just like any other case, you can be free, but remember on the back of your mind that there is something which we have promised in its premium, and you are charging more, and patient has a lot of expectations. You have counseled so much, told so many wonderful things about the lens. And then finally, if you are not able to implant, it will be a great disappointment, and the patient will be very, very unhappy, and you will also feel very bad. So, be very careful. See, I don't say, most of my talks, I don't say this step we have to do carefully, that step we have to do carefully. Everything we have to do carefully only. But only thing is, we have to keep in mind that we may need to slow down a little bit, take some more time. And another point is to make the patient feel more comfortable. See, some patients may be quite elderly people. They would be coming in with their children. They want these people to have convenience of multifocal IOLs. They want to read and do their daily activity without glasses. So we are providing them with the possible alternative, which is whatever is available right now as multifocal IOLs. But then some of them may be really old. They may not be able to focus onto the light and keep steady and all those. So during a procedure, we should not make them feel that it is a difficult procedure. They are not cooperating. There is something wrong with their attitude or their behavior during surgery. Then they will feel sorry, and they will also feel that something was not done right. It was paining. And they will attribute all these things to some kind of little dissatisfaction which they may have later on. So during the surgical, the whole procedure of surgery from the time they come into the hospital, they have to be treated little differently and a little better than other people, so that they feel that they are premium people and they are taken care a little more. And so if they are happy with all the if they are happy with all the activities going on around them, making them feel good, then they will forget some small things which happen post-op, some irritation, some kind of reading difficulty and all those. So to make them happy is another important thing. I think there will be a talk regarding unhappy patients, dealing with unhappy patients. But then surgically, when they come, somebody receiving them, somebody not standing along with the other crowd, taking them to a separate room, making them wait, not to make them wait too much, and tell them that you have to dilate, it may take some time, and take them into your procedure, either topical or block. Block means, I think either you or an anesthetist has to talk for some time and make it as painless as possible. See, nowadays it is very easy to give very slowly and gently retrobulbar or peribulbar. Retrobulbar we don't give. Peribulbar or subtenons without pain, no pain at all. So that is one way you can make them very comfortable. And bandage them and tell them to take rest, or they will be okay with that. Rather than insisting that you will do only on topical. There is no point in insisting that you will be doing only on topical. Okay, so now 12 o'clock. Start on no financial interest in this presentation. So this is one video I have recorded some time back. So we'll go step by step. Once we have selected, patient is on the table. So topical. So from the beginning, see the first point when you are sticking a drape and putting a speculum, this itself can intimidate a patient. So this itself can be painful. So try to choose a speculum which is not very hard, very broad, and see the size of the eye and the socket, and choose one which does not require too much pressure to apply on, and they should not feel this one going inside. So once this is in, then I start off with lesser illumination. I bring it down to 25% so that anybody can look at that light. So even with cataract, they will be able to look at light a little better, even if it is very high. But then still I bring it, you don't need this 100% or 75% light for putting on the drape or washing the cul-de-sac and all those. So then you can tell them very gently that there is light there, please look at the right. See, one thing is you have to go under the microscope, your own microscope once, and see what you see under the microscope, rather than telling them look at light, look at the light, tube light which is there somewhere. So look at the light, how many bulbs are there, what reflex you see, color, shape and all those, and tell them accordingly. So then they will look at it. And now, washing. Again, this is a very bad experience. If you feel yourself being flushed with saline, which is a little cold, initially it feels little odd, you know, a vasovagal kind of feel you will get. So start with drops onto the cornea. Cornea anesthetizes better. So cornea you start with start it as drops and then make it a gentle stream and then go along to the periphery and all. So here patient is nicely cooperating, staying put. So while injecting itself, while spraying with saline itself, they will squeeze. Some people will tend to squeeze. So then make sure you put one more drop of paracaine and wait for some time. Paracaine or lignocaine and not waiting at all doesn't work. So to take 10-15 seconds, wait, stop, and then continue. Come, Aravind. So, and then my policy is not to touch conjunctiva at all. So no touching conjunctiva. Paracentesis, everything choose very sharp ones and things which you are used to. Don't take anything special or something which you have not used to because this is a premium case. So things which are used to, and then I make a paracentesis enough for the second instrument to go in, because titrate your incision so that there's not too much of leak through that. It can affect your surgery, and also it can fluid keeps on flowing outside the eye and it irrigates over the eye and makes the patient feel little messy. And then the incision as good as possible, same thing what you do, a biplanar or a triplanar one with very sharp instruments. And then again, this is 1% preservative-free lignocaine, little bit into the eye and wait for some time. And then again, no intermittent splashing of saline. So you cover up the cornea with visco and then replace visco rather than putting in splashing saline all the while. And then I use viscoelastic HPMC first. So here, see, this is some pupillary membrane which is there. I'm releasing that. Nothing big deal about it. But then having a rhexis, very, very important. Centering a rhexis. So the IOL later on gets centered. Angle alpha, I think they'll all describe on angle alpha, angle kappa and all those. So finally, we'll show you how to center. But then rather than making a larger rhexis, I would go in for a smaller rhexis or an ideal sized 5.5 rhexis. But 5.5, I cannot always make a ideal sized round rhexis. So either you mark or whatever you are used to, do the same way. Don't do anything special for this, but then make it slightly smaller if possible, rather than being larger, because you need a full overlap of the rhexis with your same instrument, same technique. Once that is done, hydrodissection. Again, this is especially in myopes and all. Hydrodissection gives a little pressure on the ciliary body. Again, they feel some pain. So you tell them that there may be some pressure feeling. And also, just now when you saw, I had debulked the anterior chamber by pressing down. So it takes out the anterior capsule and also it reduces the pressure inside the anterior chamber. Now comes the most crucial thing. This is viscoat. So I include that in the package of this multifocal patients and then use liberally viscoat. So once you have hydrodissected, a lot of HPMC has gone out. Now you put in viscoat. You want this to cover because clear cornea, getting clear cornea immediately and first day post-op is very important. Otherwise, again, they'll struggle. See, already they'll have to struggle a little bit post-op to get used to the multifocality. So the cornea should not be hazy. So here again, putting the viscoat just under the endothelium. You don't want it to be in the rhexis area. And then again, to press it up onto the endothelium, I put HPMC just onto the surface of the lens. And now technique will be the same. I take a little time extra to do it little more carefully so that I don't create a rhexis tear or a PC rent. And then technique is same. Divide it well and let not the pupil come down too much. So then movements should not be too irregular inside. The current should not be too bad. So here it is finished well. And the cortex aspiration. Again here I put in HPMC first to fill up the bag and then do cortex aspiration so that you don't immediately catch the PC if the bag is empty. And then I go sub-incisional in the beginning itself, because that is the time when the bag is full, and then you can aspirate the cortex very well. So again, cortical aspiration and trying to prevent PCO is very, very crucial. So here you can see that there are cortical fibers which are sticking onto the capsule and it needs polishing. Either you can use the cap vac mode, or you can use a manual method, or you can use your saline jet to irrigate on the capsule. And underneath the anterior capsule, it's debatable, but then if at any point of time you want to explant this IOL, if you aspirate all the lens epithelial cells from underneath your rhexis margin, then it won't fibrose that very hard. So it is easier to explant these kind of IOLs if you do that, but if you're selected well and if you do well, most of them should work well. So here I'm doing the hydrojet irrigation. So especially from the visual axis, it should completely go, because minimal PCOs can affect the multifocality, and also from inside the bag also, equator also. So multiple directions. If you are used to bimanual is also good. I'm basically using. So here again, going in with sodium hyaluronate. So after irrigation aspiration, I don't put HPMC or even viscose, because it's very difficult to remove completely. So this fills up the bag, forms the space well, and then it can be removed completely and more easily. So once that is done, you take the IOL. See, very important. Use an instrument which you have to check the inner surface of your instrument. It should not be it should be ragged, should not be having serrations, and it should not create any mark on the IOL. And don't hold on to too much into the optic, like what I am doing right now. Don't do that. Catch at the haptic optic junction alone, or even the haptic alone. So, and load it as you load in your one, but keep it somewhere near. So suddenly sometimes you may drop the IOL, and if you drop the IOL, and that's it. So keep it in a sterile area, so that even if you drop it or do something, it can be retrieved. So injection is the same. Go gently. Make sure that your injector tip, see here this one, this tip should not be overriding on the IOL. Then suddenly it may go in with a jerk. So look at your injector. It may be reused multiple times. The tip might have become straighter. So it should have a little bend so that it will push the optic alone. And it can go into the bag partially. Later on you can dial it in, whichever way you're comfortable, the same way you do in regular cases. Now once it is in the bag, now you look at the overlap of the rhexis. Because I have done in this case as a smaller rhexis, you can always extend it at the end of surgery. I have seen Dr. David Chang doing most of his cases like this. He does it smaller, and then after implanting the IOL, he extends it to appropriate size to have good overlap. Because this is very important for centration and for preventing PCO later on. So so if it is covering all the areas except one area, just it has gone out of the rhexis, the optic, then again it can cause fibrosis and it can extend from that side. So please make sure that you don't make a very large rhexis, and after that aspirating the visco behind the lens also. So I just lift it up. You don't have to move this much because this lens is loaded in HPMC, so you may have to go aspirate under the optic also. And this sodium hyaluronate comes out very easily. And once that is done, then now I make sure that these two Purkinje images overlap. So this is, and that is within the central ring. And if it doesn't overlap, and if you want to nudge it a little bit, angle kappa and all those, nudge it a little bit in the bag, 5 degrees and all, small push will help you to align it properly, and keep it pressed for some time, 5-10 seconds, so that it remains in position. And these are lenses which will remain in position. And once that is done, I always put in our Vigamox or your moxifloxacin intracameral, and then close the incision and make sure that the patient is very comfortable. So that is this is the way you finish. Only one more, this is a short one, but I would say small pupils if you take, I usually don't tend to use iris hooks if possible. See, we don't want to damage the sphincter too much, and you want the pupil to be nice and acting. So if possible, continue with your mid-dilated pupil, but if it is too small, definitely use stretching devices, but don't stretch it very, very much till the limbus don't stretch. Stretch it up to 5 millimeters so that you can have a 4.5 or a 5 millimeter rhexis, and then continue, because at the end, but at any point of time, if you catch the pupil, or if it comes down further, don't hesitate to put in iris hooks, because you have to finish the case well, and it has to go into the bag. The pupil comes secondary. The rhexis has to be complete, and this is again your multifocal going inside. And if it is a small pupil, you have to make sure that it has gone into the bag, and you can always center it by matching the Purkinje images. Post-op, I think they will deal with the post-op management, and it's regular, like in any patient, especially you add sodium, the NSAID which you add, I add for all cases, and you give the same thing for, and use more of tears, because tear stability, tear film is very, very crucial for the good multifocality and the good post-op outcome. Thank you very much.